So welcome everyone, my name is Ashley Hose and I'm a Senior Improvement Advisor leading on the Reform Programme in the Transformational Change Mental Health team in Healthcare Improvement Scotland. Don't you just love a short title? Before I hand on to the chair of today, I do have a couple of short housekeeping slides to run through. I think when you get given this role, it's usually because you're the most IT illiterate person. So if I could have the next slide, please, Becca. So everyone's probably already familiar with Teams settings and accessibility functions, but in case you're not, on the screen in front of you, you can see some of the key settings. If you do require the slides to be magnified for accessibility, you can click on the Magnify Slide link at the bottom of the screen, and that will direct you to those settings. The chat box will be used for discussion, so if you have any technical problems, please put that in the chat box and Nicola will do what she can to assist with anything that pops up. The best thing to try first though is to leave and rejoin the meeting, a bit like when IT tell you to turn off and turn back on your PC. That usually resets it. Today's webinar will be recorded. The recording, the slides and any other documents we may share during the webinar today will be shared with all of those who have been registered automatically. All participants are muted and cameras are automatically turned off during the webinar, and this is to allow minimum disruption of the event. But we would encourage people to use the chat box, and then there's a Q&A box as well for questions, which I will point out to you as well on this next slide. So following on from the key settings, we'll be using the Q&A functionality for specific questions instead of chat. So on the screen in front of you is how to use the Q&A function, and Nicola will also pin this in the chat box so that you can refer back to it. We have two different Q&A bits in the webinar today, so you'll see that on the agenda next. If you think of any questions from earlier presentations as well, please feel free to ask these on the second Q&A point. And if for any of the questions that we don't get through today, we will circulate them with the recording and the documents after the event today. Next slide, please. So before I pass you over to the chair today, I just wanted to run through quickly the agenda for today. So we've got, we'll be hearing from Rachel King, who will be chairing the event. She's our portfolio lead in the Transformational Change Mental Health team at Healthcare Improvement Scotland. We will then be hearing from Gavin Gray, who is the Deputy Director at Improving Mental Health Services at Scottish Government. We'll have Donna Hekerem, who's our Associate Director in the Transformational Change Mental Health team. And as part of the reflections and Q&A, we'll be bringing in Jane Cheeseman, who's our National Clinical Strategic Lead, and she's also a Consultant Psychiatrist in NHS Lothian, and Susie Clark, who's a Consultant Psychologist in the Esteem Service in Glasgow, and also Professional Lead in our programme. We then have a section where our Pathfinders are going to come in from the work that we've been doing. So to hear from them, we've got the Early Intervention and Psychosis teams. We've got Donna Petrie and Annita Tasker from NHS Tayside, and we've got David Ruddock and Katie White from Dumfries and Galloway. And we'll also be hearing from Esther McKenzie, who's a Consultant Psychiatrist as part of the Personality Disorder programme in Dumfries and Galloway as well. And then we'll finish with another Q&A session before next steps and close. So thanks everyone for joining us this morning. I will now pass you over to Rachel.
Good morning, everybody. Lovely to be here with so many of you this morning, and great to see the numbers still rising. It's always heartening to know that there's over 150 people who are interested in thinking about the work that we are all involved in and understanding the challenges and potential opportunities for people to have better outcomes, for services to be well designed and well be able to meet people's needs in the best possible way. And that is what this morning is all about. thank you, Ashley, for running through how we're going to manage today's 2 hours together, and also what is on the agenda today. And I hope that you've all picked up that there will be a sense of, yes, we're going to be hearing from a number of different people, but also what we really want is your input. You are here because this is important to you. You are here because this topic around reform, around psychosis, around personality disorder, around doing things differently, around thinking about people with complex mental health support needs is really key to the work that you are involved in. So use that Q&A function, get your questions in, get your comments in. Do make the links with other people in the chat. We ask you to introduce yourselves in the chat so that you can make the connections across other people who are working in similar roles in different areas, other people who are working in different roles that you think you might be able to learn from, and also people who aren't part of the Scotland landscape but are doing similar work. And if you look at the people who are introducing themselves in the chat, you will see plenty of that there. So I'm going to be your chair for this morning and this afternoon. As Ashley said, I'm Rachel King. I head up the Transformational Change and Mental Health work at Healthcare Improvement Scotland. And I'm just going to touch on where we've been. So looking back in terms of the last year of reform, the reform programme, and looking forward. So the reform programme really, and I think Gavin and Diana will both touch on this, so I'll only just briefly say, it brought together a number of different programmes and pieces of work that really are about how do we do best by people who are currently perhaps not as well served as we would like them to be by service provision within mental health. People for whom accessing support can be tricky, retaining support in mental health services can be tricky, and having good outcomes in terms of mental health or mental illness symptoms, in terms of life aspirations, and in terms of being connected and part of communities, families, and friendship groups that are important to them can be tricky. So that's what you're going to hear about today, and that's what this programme really at its heart tries to bring together, the idea that we can and will do better and think about the design, the delivery and the development of services, systems and supports for people with complex support needs and people for whom we know that outcomes can be poor at the moment. So if I can have the next slide, thank you, Becca. Just to touch on this, in the reform programme or under the reform programme over the last year, we've looked at three main elements. Early intervention in psychosis, which has been in three areas, Tayside, Dumfries and Galloway, and Ayrshire and Arran, and you will be hearing from at least two of those areas later on this morning, which I think will be really interesting. And again, have your fingers ready to ask questions for the second Q&A session around that. We've also started looking at developing pathways of care for people with a diagnosis of personality disorder, and we've been doing that again in two areas, Dumfries and Galloway and West Lothian. And if you see, there's a read over between the different areas and the things that they are doing, and that bit I think is one of the key points that you might want to consider. Is if an area takes on one thing, for example Dumfries and Galloway looking at EIP, it then becomes possible to start looking at the next thing too. So again, they become on board with the personality disorder work. Thirdly, we've looked at delays in discharge for both mental health and learning disabilities, and we've done that in Ayrshire and Arran and in Grampian. I'm not going to touch on all of that work. I am going to say that we've had some really great impacts. In one area in Grampian, we've seen an over 40% reduction in delays in discharge at the Royal Cornhill Hospital, and we've seen the rate of untreated psychosis really fall from weeks to days in the sites that have first episode psychosis services. So we know that focusing on these things can make a difference. Next slide, please. So this is just to give you a flavour of what that means, and this is going to be picked up by both Gavin Gray and Diana Hekerem in a moment, but just so that you have in your mind in a visual way, what are we doing here and what are we talking about this morning? So we're talking about people getting access to the right care at the right time. We're talking about equity and inequalities. We're talking about making things even, fair, but also having a real focus on what people need. You can see our primary drivers, and I'm not going to pick those out, but I am going to say that they will be touched on by both Gavin and Diana momentarily. And from that, you can see that what we're really focused on over the next year are pathways of care, are a whole system approach to understanding how we can create improvements in the mental health system, but more importantly, improvements for people in terms of outcomes, in terms of their life journey, and in terms of where they want to get to in their own sense of self and a sense of belonging within their communities and their families. I'm going to stop there, and I'm going to invite both Diana Hekerem and Gavin Gray to come forward. They will be talking about the future of reform and renewal in mental health. And as you can see, Gavin Gray is Deputy Director for Improving Mental Health Services in the Scottish Government. Diana is from Healthcare Improvement Scotland as an Associate Director for Transformational Change. And together we hope that they will be able to paint you a picture of what we anticipate the future including. But again, I would welcome questions in the chat, as after that there will be an opportunity for you to ask questions and give reflections. Thank you very much, and over to you, Gavin and Diana.
Thanks, Rachel. So I think it might be mine. Can we move on to the next slide, please? Yeah, so I think what I was going to start by doing, and sorry, first of all, thanks everyone for the opportunity to come along and speak to this webinar. I think it is really timely. I'll talk about the wider context in a moment, but really what I want to focus on for the next sort of 5-10 minutes is looking at the direction of travel that we've set through the mental health and wellbeing strategy, the delivery plans on the back of that, where that work's going and how it aligns with the wider work around reform and renewal across health and social care. So the starting point for that is really that going back to the start of this year, the 27th of January, the First Minister set out his vision for renewal across health and social care. And he talked about 3 publications. So we've already published the Operational Improvement Plan, which was very much focused on some of the things we need to do in the here and now. There's a population health framework due in the coming weeks, which is going to set out a lot of what we're doing in that space around wider population health and prevention. And then the service renewal framework, which is due to be published by the end of June, just before the parliamentary recess, which is really going to be that high-level statement of intent around reform, looking at some of those bigger challenges around sustainability of systems and services, and setting out that direction of travel for reform and the medium and longer term, really looking at sort of 3, 5, 10-year horizons and what the things that we need to put in place. I think, there's a lot of things, I think, particularly in the mental health strategy, we've got a lot of things in there around how we get the balance right between promotion, prevention and provision of services, that push to shifting the balance of care. I think there's a lot of good things we've delivered against a lot of the things we've set out in the delivery plan, both the delivery plan and the workforce action plan that the delivery plan that supported that. But I think what I would say is, we absolutely still recognise the challenges that are there, the pressures that are on demand for different services, and the need for, as Rachel very nicely set out at the start there, the need for us to think about how we redesign services, and that's obviously not government redesigning services. How do we create the framework and the approach and have the right enablers in place that allow that to happen locally, and that we're doing that in the right way. So if we can move on to the next slide, please. This is just a bit of context, and we've got longer versions of this presentation. I think there's a lot of us going out at the moment engaging in lots of different forums around the service renewal framework at the moment. But this is just to give a bit of an overview of some of the drivers of this. These are issues that you'll all be aware of in your day jobs, but the pressures of demographics, the changing burden of disease, where those health inequalities are across the country, and the issues that they create. and how that, links, goes well beyond health into issues around poverty, employability, all of those kinds of things. The pressures we've got around workforce, financial challenges, and what that means for the development of new models of care, and how we are able to do that, and recognising the pressures and constraints and the challenges we've got there around it, particularly in finance at the moment. But I think we all recognise the need to be able to do things differently, to look at how we move more support into communities, and more in prevention, and that will be a big focus of what's in this framework. So again, if we can move to the next slide, please. The framework that we're building this around is, and again, this won't be a surprise, around these concepts of access, how we get the person-led support at the heart of that, better population health planning, but also those better issues around population health that will be linked into the population health framework, and quality of care, really, the effective delivery and the quality of outcomes, really being essential as part of that. So again, can we move on to the next slide? The principles that and this again comes from the speech that the First Minister gave at the beginning of the year, but we're building this around a set of principles or maxims around the priorities we want to take now. So that focus on prevention rather than treatment of sickness, the population approach rather than looking at where structural boundaries exist, moving more into the community rather than a more hospital focused model, people first. So how we build that support in a person-centred way with GRFI principles at the heart of it, rather than being driven by systems or services. And then the last one, and I was talking we had our mental health and wellbeing leadership board yesterday, and digital first. I think just being careful in the language around all of that, because that doesn't mean that it would be absolutely digital as the first port of call with our digital programme, which has obviously been really successful across mental health. I think we've always had the aspect of digital choice in the part of that, looking at what's best for the individual. But really what the digital first means here is just about making sure that we're maximising the impact of digital and technological innovation to support services to work better and achieve better outcomes for people, but definitely not that feeding into a presumption that digital would be the only or the immediate choice for treatment. That absolutely has to be based around clinical judgment and what's in the best interest of the individuals. So it's really about how we then use those principles to guide the design and planning of services, and how we're looking at prioritisation and resourcing around all of that. So again, if we can move on to the next slide. This is really how our thinking is starting to develop around the framework. So building on those principles, we're looking at 4 major change areas at the moment. So around redefining the hospital models of care, the future model of care for acute medical needs that works in different areas. So whether in home, community, hospital, looking at strengthening the capacity in primary care and community health. It has been essential to be able to shift that balance of care, and then how we work with citizens to put them more in charge in some of the aspects of their own care, growth of self-care, and how that sits within a redesigned system. And try to pick out, we know there's lots of different enablers across this, but particularly that focus then on how the methodology looks. So how do we allocate resource? How do we allow that to be deployed to absolutely support those principles and those shifts? But also, what are we measuring? And the premise of what counts. What you count counts. Are we measuring the right things around outcomes so that we can have the right conversations with the system about what's happening and how we support that in the longer term? So those things really the heart of this. I think across, I think these principles, like I say, have been really clear in our mental health and wellbeing strategy. I think been really clearly articulated across a lot of other strategies in the year across the years. But really, I think for this longer term approach, we need to be really, having a really clear conversation about, what has worked, where we have seen those developments, and where there have been more challenges, as a result, of all the factors I said earlier. But and where we've not been able to do that, understanding why not, and how we can actually change that enabling framework to try and, like I say, to support the development of reform and renewal approaches locally. So, and again, the reference in there to the pathways of care. So again, coming back to the slide Rachel put up at the start, those things are really clear around, actually how do we understand how people move through the system? Are they getting to the right treatment as quickly as possible? And again, we're reflecting a lot, it's still quite live in our minds, the Audit Scotland report on adult mental health services from a couple of years ago that shone a light on some of those things where those issues of access are still challenging in some areas. So how do we work collectively to get around all of that? So we can move on to the next slide. I think this is just so the penultimate one around the service reform framework, but like I say, we're looking at drafting of that document at the moment. We need to get that completed in the next couple of weeks, sorry, to try and get through the various clearance processes and everything to get that refined and signed off. As I say, there's a broad process of engagement just now, with all of us who are involved in this, and that includes, folk in acute services and social care, primary care. It's a very much a cross government or across the DG approach to all of this. And we're out talking to different groups in fora like this at the moment for the next couple of weeks to try and refine our thinking and all of that. And like I say, looking to publish towards the end of June, and then get the focus on what the implementation of that looks like. And then if we can move on to my last slide, the final bit I wanted to talk about is how that sits with our delivery plan. So, like I say, we published our strategy in July 2023. We published the action plan and the workforce action plan in November of that year. A lot of work has been going on across government and with all our partners around implementing that, and we've made progress on a number of fronts. There are a couple of areas that have been challenging because of the constraints we faced, but made good progress, I think. But very aware that despite the increased investment, the money we've put in the system, the increases to the workforce, the demands, and pressures on services are still increasing, and it creates a challenging environment. And we know and appreciate the pressures that will put on all of you in terms of the day jobs and how and the impact that's having. So we're really keen that we, when we're establishing this framework for what's going to be happening across health and social care services, that the work on mental health is absolutely aligned with that. So we'll be doing a lot of thinking over the second half of this year, really, about what we need to do in mental health, taking that whole system approach that fits in with that wider reform framework, but allows us to really get into the detail. And I think, again, going back to the slide at the start from Rachel, gives a really good sense of some of those areas we've got to be thinking about how we support those with the most complex needs. Do we have the right governance and operating models in place that are supporting change? Are we putting our money out in the right way? So these will all be the things we'll be having active discussions about over the rest of this year and into the start of 2026 as we look to refresh the delivery plan and try and get those focus on what the next set of things we need to do to continue to drive the change. So hopefully that's helpful. I mean, obviously you'll understand there's a lot of other a lot more complexity behind all of this, but just wanted to give a quick run through of that overall direction of travel, and happy now to hand over to Diana to talk about how that links with the work that His are doing around all of this.
Thanks, Gavin. That was really helpful, and I suppose what I want to do is really build on that from Healthcare Improvement Scotland's point of view, and how we want to build our programme of support around that reform agenda in a way that supports and works in a practical improvement way with the system. I mean, I've been doing service redesign and I don't know why I jumped slides like that. My apologies. I have been doing service change and transformation in health and social care for over 2 decades now. And I think I don't think it's just my age, the pressure that I hear in the system, the challenges and stresses on our delivery teams is like I've not seen it before. My husband works as a social worker in the system, and I know the pressure he feels and the pressure he feels dealing with young people who are struggling with their mental health. So it's a really, really challenging time for us. And as Gavin said in this, and what Gavin has set out, that backdrop of increased pressurised demand is against a system that's needed to change. Now, since Christie and since Reshaping Care for Older People, we've known that the system has need to change, and if it doesn't, we'd end up with a system that was under unsustainable levels of pressure. And we haven't managed to do the change that was required, and that has then been exacerbated by COVID and the sort of pan-global financial pressures that Scotland's seeing itself under now. So that degree and level of change is higher than it's ever been before. The imperative to do really complex change at pace is higher, but against a system who has less and less capacity to be able to, capacity both in time, but capacity as well as in well-being to be able to cope with that. So we're really thoughtful about how do we deliver against this when there are no easy solutions. And if I think about even our working in the Scottish Patient Safety Programme, we're looking at point of care safety issues was the most important goal. Actually now recognising the flow in the system is what's causing some of our greatest harms, makes it a much more complex and difficult pace, because you can't just put in place a single measure and expect to see an improvement. The world is really challenging and difficult right now. That doesn't mean we should be without hope. What we've learned from doing the work in both personality disorder and early intervention and psychosis is that change can happen by embracing, as was in the logic model that Rachel shared, by embracing change that recognises that whole system place, by embracing the kind of change which recognises people's whole lives, that education and employment alongside CBT and psychology-led interventions it can bring change in really important ways. These kind of outcomes where people are back into employment, they're stopping using substances, that they are staying engaged with services, they're back into accommodation, that they are thriving. This is possible even in with all the challenges that we've got now. So what do we need to learn from that? But we also need to learn that it has an impact on the system in general. We know that some of the challenges of putting in some of services like this is the impact that they have on community mental health teams or general adult psychiatry, where being able to provide a really good service, a sustainable service, and a service that staff value and recognise and meets their vocational needs to work in mental health. That takes those staff and that resource away from other parts of the service. So we need to be really thoughtful about our balancing measures when we do this as we go forward. We also know from learning about people with mental health or learning disabilities through our delayed discharge work is the issues are pan-Scotland and they are complex and often out with the control of an individual service, an individual health and social care partnership, or even within an individual board, where the mix between private providers and statutory sector duties and the rights of people can end up sitting in conflict. And it means that for somebody to be able to be looked after and supported in the place that they think of home, can the way we currently have our pathways of care set up take up to 2 years. And none of us, nobody working in the system, nobody working to support somebody going through this feels that this is okay. And so it's really challenging for that individual, it's really challenging for the services, and it's really challenging for the staff working in this who've expressed to us how hard it is to look after people when they know they are not doing or able to support that person to the best that person needs. And that moral injury is another one of these imperatives why we need to work to tackle these issues together with teams. And I think what's been really helpful and a real bonus for me over the last 6 months is working much more in a different way with our policy teams to be able to bring these issues through the direct work to life in really systemic ways like this that allow that thematic analysis and change to take place about issues that are then out with the control of local areas to be able to influence and change. We're also looking at the Scottish approach to change, that within that we've learnt that change is complex. We've learnt that change is really difficult. We've understood that the capability and capacity to do change through our evidence review, that the capability, culture and capacity to do change is hard. And can often be put in place. Because my question is, we've known for a long time about how much the system needs to change, and we've known for a long time the kind of changes that we need to make. The evidence is there, but we've not managed to be able to make those changes. We know that that can also be impacted about the flexibility of a system to be able to adapt and spread and make sustainable initiatives. So again, that early intervention psychosis and personality disorder work, how does that adapt to local systems? How does it hold itself as being sustainable? And how do we embed what works across Scotland, recognising the different configurations of services and workforce challenges and demographic demands in different areas of Scotland? And we also can see, and you know, what Gavin's slides about where Scotland is going, there will be diverse improvement priorities across Scotland that we need to consider, and it's a lot on an individual team to kind of be told, change this, improve that, change this, improve that, change that thing over there, that we don't get to work through a whole change cycle. So we were asked by Scottish Government to look at a model of change, not the framework for what you're changing into, but how can that change happen so that we can deliver that evidence base, so we can deliver those aspirations that Gavin talked about. So this is the Scottish approach to change. When you get the slides, that link on that slide will take you to the toolkit and the website about this. And what this enables us to do is to focus on that change cycle that we really need to understand both at a service and an individual level, understand what's going on for people, understand what's going on for those people who are delivering services, and understand what's going on for our system flow, our finances, our workforce, our resources, and then use that understanding through a period of continual learning to define and implement and embed a different way of working. So it is this approach to change which will be embedding our work around reform for the next year, and to work with local areas to help them have the tools and capabilities to be able to do that work as easily as possible. Our real desire is not to bring you new theory. This doesn't replace quality improvement. It doesn't replace population health. It doesn't replace planning. It doesn't replace engagement. What it does is picks out for teams in the most practical, simple way possible the steps that will enable the work that Gavin has set out that we need to aspire to be able to do that. So instead of reinventing the wheel about, I don't know how to start a project, I don't know how to map a system, that can be made as accessible and easy as possible. We've been building the early intervention and psychosis teams. We've been working around that. There's a guide that gives real practical, this is how you do your project management. This is a kind of sample of a way to set up your project management to kind of help shortcut some of that the work that's required to do change. So recognizing that limited capability, but also allows us to focus on the things that really matter, how some of the rigor that goes into it, the culture that we need around our leadership, the kind of way we need to structure our governance and finance and our data and measurement to enable us to make complex change work. So that is all part of this tools, and so both sort of guides about how to do change and the tools that you can use, so you're not, as I say, hunting through thousands of things. But doesn't require you to be a specialist in anything, and is certainly not replacing or building something new. It's a really practical basis to enable you to kind of pull on what we know works well about change. So really our focus for the next year is to help the health and social care organisations in Scotland to think about and build and develop at a system and at a delivery level what a pathway of complex mental health looks like, from someone's home through specialist services and back to ongoing sustainable support for somebody in their home and homely environment. And it is that focus on looking at those complex pathways of care that are rooted in somebody being and being cared for and supported where they want to be, and utilising our teams that we've got to support that and add value within that journey in the most optimal way. So that's our ambition for the Healthcare Improvement Scotland Reform Programme for the next year. So I'll now hand back to Rachel, I think, who's facilitating the questions.
That is correct. I think we might want to move on just 2 slides, unless we have already, and it's my slides that are now not quite in the right place. Let's have a look. Here we are. We're on reflections and questions and answers. Now, I don't know if you've not all quite woken up this morning, but as far as I know, the Q&A section is currently empty. So anyone who would like to ask a question or give a reflection, I can see that someone has done that in the chat just now. It's helpful if we can pull them into the Q&A just so that we can see them all in one place. If you've not got that button on the top of your on the bar at the top of your screen, then don't worry, do just put comments or questions in the chat. But I'll also invite Dr. Jane Cheeseman and Dr. Susie Clark to join us with their cameras on, if that's all right. And I think we might have a question in the question and answer, and we will just come to the question that's in the chat, which is probably also in the Q&A now, which is from Aisha, who is asking about whether the provision for IPS employment specialists working in community mental health teams. So it's bringing together some of what we've just heard and thinking about where will that provision be across Scotland. I just want to note that I think what we've heard so far is really about what do we need to think about at a macro level? What is the policy? What is the culture? How can we make that into the real everyday practice for people who are working in services and people who are being supported within services? And the reason that we have these 2 halves to this webinar is because we have an opportunity now to reflect on that, the policy direction, the way that we can think about things nationally, the big issues that we have around inequity and inequalities and in our health and well-being. And then to see after this section, what are the ways in which services are already making change possible. Diana commented on that. Gavin displayed that ambition that we want to make that change possible for people. So I can see we've already got people answering that question in the chat, but if I can bring in Susie, I think you may have had your hand up there, presumably to answer that question. So it would be great to hear from you just now. And then I have a question for you all after that.
If I can say 2 things, I'd quite like to answer the question, but I just wanted to reflect a little bit on what you had both said, Gavin and Diana. I was really heartened to hear about the idea of the kind of priorities, not just around access, but also around personalised care and also on quality. Because one of my concerns around about psychosis, which has been very much the area that I've worked in all my career really, is that people with psychosis don't ask for help generally. And so they aren't picked up by the HEAT target. They don't get access to all the interventions they need. And they often come in through unscheduled care. They use the full pathway. They use inpatient care. They need assertive outreach, but they also need all the evidence-based interventions. So I like the idea of a pathway that has the specialist need at the different time points that people need, that also take on board all the different services and how those systems work together. I think that's a real kind of good way to be going, but also that focus on quality. What is the quality? What are the quality interventions that people get that really improve their outcome? And we know that intervening early, giving people access to psychological therapies, giving people family support and also employment support can really make a difference to outcomes. And although some of the people through my service will continue to use mental health services, they won't need to go into hospital so much. They will often be working. And that's the direction of travel I think we want to go in strategically. So how do we scale up this EIP work in a meaningful way, because it helps take the focus back to what are our mental health services for? They're for people with complex, severe and enduring mental health difficulties. So I just wanted to say that, and then I'll try and answer the IPS question, which is one of the things that I think EIP can give, the pathways, is that people go into CMHTs and they get a bit lost. They bounce around a little bit around the CMHT between different disciplines. And actually the concept of a pathway is something that EIP can bring the whole system. What do you offer people when? And often the final point in that pathway is, let's think about getting back to work. Now, it might not be paid employment. It might be voluntary work in the local shop for 2 hours a week. But having a meaningful role makes a massive difference to people's lives. And as far as I'm concerned, our employability worker is the best thing, one of the best things that has happened to my service in Glasgow in years. And our return to work employment education rates are really good. I know the other EIP teams have identified that too. So but why do we, these people could also be employed and housed in CMHTs. So you're looking at a pathway of care and people then going on to live meaningful lives in their community. So thank you for that opportunity.
Thank you very much, Susie, and really helpful reflections as well. I can see that Jane and Gavin want to come in, and I'll just let you know that there are now 5 questions in the chat. So I'm going to bring you both in, but I'm going to try and also move us a little bit at pace. Jane, in you come.
Yeah, so I mean, super quickly, I think there's a lot in what we've heard that is really heartening around the direction of travel. I am literally sitting in my clinical area this morning. So if there's any interruptions, I apologise. And so all of the clinicians who are on the call today are living and breathing the pressures on services, the difficulty around delivering safe, effective, person-centred care in this current climate that you've spoken about. I think, we're talking a lot about, redesigning across pathways of care, which I think is going to be super important, because one thing we know in mental health is people are complicated. They have complex issues. They frequently have, a number of conditions, so psychosis and polysubstance misuse. So we need to think about services that work for people overall. And I think what you were saying, Gavin, around, who do we prioritise? Well, for me, I think we prioritise the people who have these severe, complex illnesses, because we know they're the people that use all of the pathway, or are at risk of using all of the pathway. And we know they're the people that we have evidence-based treatments for. So we know what to do to help them. We know what to do around things like preventing relapse, but we need services and pathways of care that help us to do that. And that, the other thing that I think we've touched a little bit on is we need also to think about transitions of care very, very carefully, because we know that these are where some of our big safety concerns come up. And we know that this group of patients that we're talking about, that I suspect most of us in the room are working with, are people who are sadly at high risk of suicide and very negative outcomes. So I think that, we need to think about making sure that they do get the right care, the right treatment in the right place, and that there's a kind of a safe transition of that care, so that services are linked up and working together, especially at the moment when there's such high pressure on services. And I think it is really important. I think Diana touched on, one of the elephants in the room around safety is trying to provide safe, effective care in a environment where we don't have that kind of level of resource, and that services are so stretched. So I think, I think it's very heartening to hear that the thinking is joined up around this, and I'm sure we'll be hearing, and there'll be great examples from the EIP work and the personality disorder work and other parts of the programme that I think will help us, you know, to think about that flow through the system as well, and the discharge without delay kind of work that's been going on, which needs also to be embedded in that because of this kind of pathways of care issue. So, you know, I think what we've heard is heartening, and I'm sure we'll hear some good examples that will help us think about that for a wider patient population.
Perfect. Thank you very much, Jane. Thank you. And Gavin?
Yeah, I won't repeat any of the things that Susie or Jane have just said, but, you know, I agree with, you know, all of that really. And I think the big challenge for us in all of this then is how do we do that, and how do we take, so I was at a learning event yesterday with psychologists, which was, you know, great, being in the room for the day, talking about a lot of these issues and around how do we facilitate those changes, you know, what do we need to do around the design of services, how could they look differently, how can we get different skills mixes in there using different professions in different ways that allow us to address some of these issues. But how do we, how do we create that framework for change across the system? What are the things we need to put in place that will, you know, like I say, we know it's not a perfect solution to all this. It is really difficult and complex, but there are things we can do. So, you know, as we go, you know, grateful for thoughts here, but, you know, as we go beyond this, really interested in the how, what are the things that we need to put in structurally to create that framework for change that will allow us over time, hopefully, to achieve all the things that you're setting out.
Thank you, Gavin, because I think that in some part is being answered by Amy McLean, who's said that there's work to do with people and communities and the population to get buy-in for self-care prevention, so that people know how and where to access support and aren't just all trying to get the same support from the same place, because as Jane has outlined, and as we know very well, the pressure on the system is absolutely astonishing at the moment. Susie, I'm going to come to you in one moment. I was just going to say that I think I'm going to blend three of the questions, because there's one question that's around, you know, we're talking about pathways of care, but are we also talking about access, and what does access mean? Can that include ideas around self-referral? Can it include being able to advocate for oneself? There's a question in there that's about how does NHS Scotland work with things like the DWP, you know, to think about the impact of what it is to be in a mental health service. And someone's commenting that actually being in a community mental health team means that people have access to disability benefits, but are worried that if they're not part of that secondary care service, their need is seen differently, and so therefore they become vulnerable to all the things that we know happen to people when they are encouraged back to work too fully. So we might just start with those two, because I think they are the sides of, you know, the two sides of the same coin, really, if that's all right. So reflections on that. But Susie, I'm aware you've had your hand up anyway, so it might be, Susie, that you want to come in on your point, and then we come to, well, we've got two hands up already. So Susie in 1 minute, and then Gavin and Dan.
So I guess I just wanted to say that I think there's a lot to be said about quality, and part of the things that we struggle with. So there's outcomes we could add to the mental health outcome framework that would allow us to focus more specifically on the most complex mental health. But I think we don't have the business intelligence to back that up. So there are some structural things that would really help some of this work go forward. I guess that was really what I wanted to say. But I do think there's something more broadly about people with complex mental health problems need to be the main business of mental health services, and sometimes I think they've got lost over the years because they don't necessarily ask for help or join waiting lists, and I think they're already marginalised. People risk being more marginalised if we just focus on time and waiting times targets. So for me it's about how do we make sure the system is accessible for the people who need it the most, actually, and also that they get the quality interventions. And that, as I am very fond of quoting, you know, that the uptake of psychological therapy in Scotland for people with psychosis is approximately 1%. Internationally, it's 30%. So people with psychosis don't get psychological therapies in Scotland, really. And that's something we can improve on. So how do we make not just that intervention, but other interventions available to people who need it the most in the preventative way, because it will improve their outcome, it will reduce their difficulties in the long run. I will stop there and hand over to your question, Rachel.
Thank you. Thanks, Susie. Points very well made. And I can see that people are making really good comments in the Q&A section, talking about fairness and reducing inequalities, and talking about having a multidisciplinary team, and having observations for all. Gavin, your hand was up and now your hand is down. I'm just going to check with you. Would you like to come in?
No, I was going to come in quickly. More on the DWP point. So actually, before I came into this job in mental health, one of my previous jobs was around employability, and particularly the transition of the Fair Start Scotland and the establishment of that. So I think there are some really important things in here that we still need to get into, and actually the Mental Health Leadership Board, which I was also talking to yesterday, there were some connections around that. So I think we've still got, there's a real appetite, I think, to do more in that space and to look at how we can make those connections around support for people with mental health issues, understand those links. So that's something that we're actively discussing with the colleagues in here who deal with employability services, and we'll be taking that forward. So thought it would be helpful just to say that those conversations are very alive within government at the moment. It's something we're really get aware of, that there is more we could do. And I think the earlier comments about how we get things like IPS and everything embedded in that, and what different partners are doing. Part of the approach we've taken to employability services over the years is to try and make them less isolated around just search for work, but actually allow it to be more integrated into the wider health, social care, and get a more person-centred approach that realises that employability pressures, as you all know, aren't necessarily always just about your ability to search for a job. It's those wider health and societal issues that you need to deal with in a whole person-centred way. So hopefully those changes that we've made over the years will allow more of these things to happen in a more joined-up way in future.
Yes, thank you, Gavin. That is heartening to hear, and I think speaks to some of the other comments that are in the chat that are about how do we have a focus on people, how do we ensure that we are creating a landscape that is free of stigma and discrimination at scale, and how do we understand people's needs beyond health, to make sure that we are meeting the whole person. I'm going to come to Diana, then we're going to wrap up this section. I'm aware there are a number of questions that haven't been answered within this. We will answer all questions, so don't worry if your question hasn't been asked, or if it's been included in another question. We will come to each question individually as well, and respond to it as part of the feedback from today's event. Diana.
Thank you. Yes, and I think so. I'm going to say a simple thing, which is not simple in real life, but we have set ourselves a goal to hold ourselves to account for designing out exclusion in all the work that we're going to do around looking around change, and pushing ourselves to hold ourselves to account in everything that we do around in our transformation work about whether we're doing that. And so being really thoughtful in our work around mental health, and similarly the work that we're doing in with people with addiction, is that is tied up in things that are different to a physical health demand, and that are so wrapped up in benefits and right and what it means to thrive, and how limited and different these opportunities are for different groups of people. And so as we do our tools like our system mapping tools, as we use some of those journey map tools that we've got, those are the ones that bring to life when done well, and when we use the method that we do, that really bring to life where people's touch points are that are not always the formal service, where they could be improved, but what people need to thrive and what that looks like, and the sustainability of that wider life to being able to support somebody to either live with or to be supported through their mental health needs. So I would just like to show that the approach that we want to take should bring in and illuminate things, and the experience of doing the work around adults with incapacity and coming home has shown to me that benefit of that real close relationship that we've had with policy colleagues in being able to thematically understand some of these issues from a person's point of view, and being able to work with policy colleagues about how can affect be changed in real terms in Scotland in ways that aren't just aspirational.
Thank you, Diana. It's a good place to pause for this question and answer session around, being aspirational but being realistic and getting change actually happening. So thank you to Susie Clark, Jane Cheeseman, Diana Hekerem and Gavin Gray for being the first panel of the webinar. I believe you are back on later. So thank you very much. And I'm now going to move us on to the second part of our webinar, which is about what does change look like? If we're going to do this, what does it actually look like? And that will play into the answer to some of the questions that are as yet unanswered in the chat around peer support, around how do we engage other boards and areas of Scotland to put in place things that we know make a difference, around access to psychological therapies, around the focus on quality, and around understanding the importance of having community supports that people can access as opposed to statutory sector only in terms of inpatient settings and secondary care. So without further ado, I will bring in Donna Petrie and Annita Tasker, who are part of the multidisciplinary team in NHS Tayside, who are part of the Connect service, which is their early intervention in psychosis service in Dundee. So Annita and Donna, if I can ask you to put your cameras on and begin your presentation when you're ready. Thank you very much.
Great, thank you very much, Rachel. If you just move on to the next slide, please. And the next one. So just thank you very much for inviting us here today, just to give a snapshot of the work that we've been doing in the service. So just to set the scene, obviously NHS Tayside, we have a population of around 400,000 people and are covered by 3 health and social care partnerships, all with kind of different geographical regions. Our focus so far has been in establishing a hub in the Dundee, which serves an urban population of around 142,000 people. Future aspirations would be to develop the spokes so that we've got a hub and spoke model in Tayside, with the spokes being in Perth and in Angus. Next slide, please. So this just gives an overview of the staffing that we have in the Connect service at the moment. So mental health nurses, occupational therapist, clinical psychologist, healthcare support worker, peer support worker, we've got admin support, and we get an ST6 psychiatrist for 3 hours a week. Next slide, please. So this slide just gives a little bit of an overview of our caseload information up to the end of March this year. So as you can see just from the first diagram, we accept referrals from any source. So we have a good range of referrals coming from different sources, and we accept from anywhere, including self-referrals, to reduce barriers to access and prompt assessment and treatment. Then from the second graph there, our referral outcomes, you can see that we have quite a lot of referrals coming in, and then around 48% of the people we assess actually come on the caseload, and that's about 39% of the referrals that we actually get that are taken on the caseload. We actually have quite a high degree of assessment, so we work closely with the community mental health teams, but we don't tend to do joint assessments with them just because of the way the waiting lists are in Dundee. We wouldn't be able to achieve our targets if we did joint assessments. So we do quite a lot of community initial assessments, and about 48% of those assessments are taken onto the caseload. It also just shows a little bit about what happens with our discharge destinations. So just under half of our caseload are going back into primary care. Over a quarter are going into mental health services after our 2-year contact, and over a quarter of people actually move out of the area before the end of their 2 years with our service. Just another couple of pointers there just to show that obviously the majority of our caseload are male, and by age the majority of people that are on our caseload are in their 20s, and as of the end of March our current caseload is 31 people. Next slide please. So just to show the level of deprivation within the population in Dundee compared to our caseload, so the Dundee population, 11.4%, live in the most deprived areas, whereas 72% of our caseload live in the most deprived areas of Dundee. So it just shows some of the inequalities, I suppose, that Gavin talked about earlier, and the importance of having EIP to reduce the disease burden. Anita will talk a little bit more further on about what this means for us in terms of the complexities and comorbidities that we see in the Dundee population and our caseload and all the challenges that brings. But first of all, I'll just give a brief kind of overview of our impact data and feedback that we've gathered so far. Next slide, please. So some information on our service impact. So referral to treatment time, everybody within EIP services need to have started treatment within 14 days of referral. At the moment, we're seeing 98% of people within 14 days and 82% of people we actually see within 7 days. And the small percentage of people that we don't get within 14 days is not because we've not offered them an appointment within the 14 days, it's because they've been difficult to get engaged. Our duration of untreated psychosis has reduced from months down to under 3 weeks. We've looked at potential bed saving costs, and at the moment, at last calculation, potentially EIP service in Dundee is saving over £500,000 in inpatient stays. Our readmission rate as well is at under 23%, which is well below what the NHS Tayside 5-year average is at 47%. We have less than 5% of our caseload on compulsory treatment, and I think there's only been 2 people who have remained on compulsory treatment at the 6-month point with us. We maintain monthly engagement with everybody on the caseload, so we've got about 100% engagement month on month with people, and less than 3% of our caseload we've discharged due to non-engagement. From the very outset, we engage families in care planning, and 88% of our families are engaged with that right from the very outset. And another really important figure, which relates back to what was being discussed earlier and Susie mentioned as well, is getting people back into sort of some form of meaningful activity in their life, work, education or volunteering. 60% of people that we work with are back into some form of meaningful work or volunteering, etc. from 6 months they're on our caseload. Next slide, please. And I thought it was really important just to capture some of the actual stories and personal sort of journey points that we have with people on the caseload from the actual people we work with and the families that we've been working with. So this is the part for me that really hits home, that actually EIP services are really beneficial, and the work that we do here is really helping people to get back into experiencing meaningful life, employment, family relationships, etc. So the first part is from a family member, and this was feedback left on care opinion. And they're saying that they never expected one of their children to have a serious psychotic illness, as most people won't expect that to come across them. The staff very much work with us as a family, providing reassurance and support. Almost 5 months on, due to the intense regular input he's had, he's reclaiming his life, been supported to make more positive social networks, is back at work, and has been supported to break a 10-year cannabis habit. And then the second one is from somebody who reached the end of their 2 years with us, had been really, really acutely well when they came onto our caseload, and actually had a number of touch points where services could have intervened before he came to us. And there is a patient journey map that maybe Ashley could upload or share with people at some point for this patient. So he was saying that his time in hospital was really scary, but the staff always treated him as a person and held hope until he could hold hope for himself again. And when he's looked back over his journey, what he wants to say to other people is, please ask for help, and if you don't get it the first time, please ask again, because with the right support, we can recover from psychosis. Next slide, please. And just another few comments from people that we've worked with, just around stigma and understanding of psychosis, and I suppose on the impact that psychosis can have on other things. So we've had quite a few people that have came through our service who have been homeless, and you can't really do any meaningful intervention work with somebody while their basic needs aren't met. So doing a lot of work around that initially has been the focus for some people. And just that the support provided has helped people understand their triggers, how to manage their stress levels, early warning signs, and understand their experiences better. And I'll just pass over to Anita to finish off the presentation.
Next slide, please. Hi everyone, I'm Anita. I just wanted to give like a very brief, quick overview of the people that we work with in our service, just to think about them from a kind of individual level, and also think a bit about the kind of comorbidities that people come into our service with. So that psychosis is often the tip of the iceberg of the kind of things that they want support with. So if we have a wee look at this graph, we can see that out of 56 people we've had in the service, there's quite a lot who come in with some sort of substance or alcohol use. So we've got, I think that's 32 people have been using cannabis prior to working with our service or at the time of working with our service. And as we said, that actually a lot of them have stopped using cannabis through their time with us. We have quite a lot. We've sort of looked at this as sort of anxiety and depression. A lot of people struggle with this on our caseload, but we have 24 who would fit the kind of criteria to be seen by psychology services for the level of anxiety and depression that they're kind of coming in with. We have a few with forensic issues, a few who have a diagnosis of personality disorder, and I know that is a kind of controversial term, but that is something that we do see in the service. And I've put trauma here, and I have starred the trauma because good portion of the caseload that we work with have a trauma background. You know, if we think about the stress vulnerability model, trauma is a massive factor there, but I've starred it as this is the individuals who see their trauma as being at the forefront of what is going on for them at the moment and the help that they need for that. So it's just to give a kind of brief snapshot that somebody might be coming in a psychosis service, but this is kind of what they're coming in with and the kind of things that we want to support them with. Next slide, please. Also to think about the kind of some of the factors that we think about as a team. So we do have quite a few that have come in with pre-diagnoses of autism or ADHD. We have a couple in our caseload who have cognitive issues, 2 of them which have been assessed while they've been with us, to sort of see that they have the difficulties. And we have 3 in our service that identify as transgender or non-binary, and we support and adapt our service to work with individuals who identify as trans or non-binary. We also, if you can see if this is a little chart about ethnicity, a good portion are white Scottish, but we actually have work with a lot of people from all over with lots of backgrounds, and this is what they've identified as. And that actually has created a challenge for our services and how we adapt the support and the work that we do, and even things like adapting the sort of PSIP workbooks, or thinking about the goals of our service and what our ideas of what someone's recovery might look like versus what a culture or ethnic goal might look like. So we do a lot of adaptation for that, and that's about getting to know the person as we would with anybody that comes in, but also getting support from maybe external services who can give us a bit of advice on how to support these individuals. Next slide, please. And this is just brief to think about, this is some of the things that we think about when somebody comes into our service: culture, their language and how we adapt for that, what their pre-employment and educational status is so that we can think with them about where they might want to get to, their developmental stage, where that sits in terms of their sort of age versus where their actual development is. Their family makeup and trauma factors are always things that we think about. Next slide, please. I'm just aware of time, or I'd go into more detail. And this one particularly was for me. So this is individuals that by the time they come to see me, they've actually done quite a lot of work with their key workers to go through a lot of the psychosis stuff, and a lot of them will have done sort of low-level anxiety management. So when they come to me, psychosis is the thing that they're in our service for, and these are the sort of things that people might consider as what they would be working on. But actually what I find is that when I work with somebody, it's very collaborative on what we choose to work with, and the things underneath the surface, that's what the individuals have chosen to work on. That's what they feel is the most significant thing for them at the time. We obviously account for the psychotic symptoms if they're ongoing and how we support that going forward, but actually what's underlying that is things like anxiety, self-esteem, assertiveness, relational building, all the things that give them the bedrock of having a more functioning life, so that actually they're not within that stress vulnerability of potentially having further psychosis down the line. So it was just to give you an idea of the kind of things that people come with. Next slide, please. And just to finish off, they asked us to sort of think a bit about challenges. And I suppose for us, the biggest challenge in our service was that the service actually started in August 2022, but we didn't have all the key roles at the time. So psychology didn't start until April 23. The nursing team at that point weren't permanent, and they were just kind of ad hoc for some of them, which was really difficult to get a service started. And I think once we got our new key workers, new nurses started in the May, I started in the April, that's when we really got the service going. But what one of the big challenges has been is that we've actually gone through, I think, 4 different psychiatrists, because we don't have permanent psychiatry. It's people who are ST6s, and they're choosing to work with us for that period of time, which they've been fantastic support, but it is a big challenge when we don't have psychiatry there to be able to think about things at a very quick pace, and having to go to the community teams for who hold RMO status. And then also for us, we're a brand new team with our kind of gold standard goals and lots of enthusiasm, and trying to integrate what our ideas and our goals are into kind of the existing structures and the services, so CMHTs, who have actually been fantastic at supporting us, but some of our pathways are different, and it's about how we integrate that to give the best support to people. So that's just to give you a quick snapshot of who we work with, and how great our service is and how we love working with the people here.
Yeah, thank you very much. That was really, really great to hear. And you can see, I meant to say earlier, please can we give virtual applause to anyone who's speaking, because it's so difficult. We do have hands up. I'm hoping that they actually meant to clap, because we won't take questions just now. But if you do have a question, put it in the Q&A section, and we will, of course, be asking for people to respond to those. Donna and Anita will be able to do that towards the end of the webinar. So I'm going to move us swiftly on. We are slightly behind, and I would like us to have time for the Q&A section later. My understanding is that it is Katie and David who've got the next slot. I'll try and pop up on your screen when I think we should be drawing to a close, if that's all right. So thank you very much, Donna and Anita, and over to you, Katie and David. Thank you.
Thanks, Rachel. So yeah, I'm David Ruddicker. I'm the EIP team lead, as well as unscheduled care service manager in Dumfries and Galloway. And we're just going to talk a little bit about our service down in D&G. So if we go to the next slide, please. And then even the one after that. So my slides, let's see, we're working, so I'm kind of clicking along as I go. Hopefully I'm on the right one. I'm on the one of the map of Dumfries and Galloway. So just to give a bit of context of our area, because I think it's really important to know when thinking about how we've set up our EIP service to adapt to being a rural area. So as you can see, we're a pretty large geographical area. We cover 6,500 kilometres really, and we've got a population of 147,000 people. And the population tends to be dispersed into pockets of populations, but what we've found is we've managed to have people on our caseload that have been in the most rural of areas within the region, to the point where there's been any areas where there's very little phone signal, transport links are very poor, and even IT systems are difficult, which has put challenges on utilising near me and things like that. We have 5 locality community mental health teams within D&G, so it's split throughout the region, which has been a big part of the way we've built our service to fit in with the locality CMHTs as well. And there's also quite significant lower socioeconomic areas, and I think our data mirrors a lot of Tayside's in terms of a large portion of our caseload are from lower and deprived areas within D&G. We've also got a couple of university campuses, but we don't see a large influx of students from out of the area. And in fact, we haven't had any within our caseload, but it does give a bit of a younger population to the area, as we are an ageing population down in D&G, as is most of Scotland. I'll pass over to Katie, who's going to discuss some of the challenges that we've came up against and how we've adapted to these as we went on. If we can move to the next slide, please.
Thanks, David. So as David explained, we've got 5 locality CMHTs over quite a widely ranging rural population. So we looked at the possibility of using digital kind of first interventions near me, but clearly this is a client group that really do benefit from face-to-face engagement. So that's not an option for everyone. What we have been able to do is utilise the likes of Near Me for psychology appointments, for occupational therapy appointments, and perhaps as a combination of care. So for instance, our colleagues in the community mental health teams have maybe been able to facilitate contact using Near Me for service users in Stranraer, if we haven't been able to go out that way for a specific appointment. We've built up really positive relationships with the community mental health teams, partly because we're a small kind of service with existing relationships with a number of our clinicians. We got to know everybody really well, they know what we do, and we've been able to kind of build a service where we have an identified kind of co-worker from the community mental health team who kind of works alongside ourselves and can support additional support for service users at points of time where we need that extra resource, because it is so limited with the resource that we have. We've also spent some time investing in team meetings, provided some training to the teams so they can know what our service is about, and really try and kind of advance the movement towards early intervention psychosis. Obviously, it's already been mentioned, this is a national challenge with the limitations of psychiatry input to areas, and I know Tayside have experienced this. We've experienced this. I think everywhere in Scotland experienced this. Initially, we had as part of our pilot the option of ring-fenced time for psychiatry. Ultimately, that wasn't possible with the resource being limited in our area. So what we moved towards doing is a kind of shared care model. So the psychiatrists within each CMHTs remain the RMO for our service users. In some respects, this actually has really helped in terms of continuity of care for the end of a patient's journey with EIP after their 2 years allocated with us. It provides an opportunity for there to be consistency when they're passed over to the CMHTs. But also we were able to get some pharmacy input for our team. So we have a mental health pharmacist who has been really extremely helpful in assisting us with matters relating to medication changes, having conversations with service users about medication choices, and facilitating engagement in treatment. Lastly, the kind of issue that I suppose has been a major challenge for us is about timely referral. Initially, when we were set up, I think probably this is reflective of the experiences in Tayside too. Our initial referrals would be kind of later on in the point of somebody's admission, for instance. We were really pushing for referrals to come at an earlier point in patient journey, and I think that largely that has been the case. We're seeing people earlier on in the onset of their difficulties, which is really very important in terms of outcome. I'll pass on to David now for the next slide, if we can move on.
So just going on to some of the impact that the service has made since we started back in June 2022, which seems like a blink of an eye ago. So we've had 97 referrals to the service and 47 have been accepted for EIP treatment and support. What we've got on the table below is about our referral to treatment dates, and you can see there that it's pretty low. We've done quite well of meeting the standards of 14 days. I think we've got 44 out of 47 we've met that, and our median referral to treatment day is actually 2 days. I think that's quite indicative of a lot of our referrals coming from crisis services or inpatient services. That continues to be quite significant in what we're seeing. So people are seen pretty quickly. They'll then start on medication or started on some form of treatment at that point. Our dates for, I think, CMHT referrals are slightly higher because we do try and do them as joint assessments with the CMHT, and it's fitting it in within their clinics, but they are pretty flexible in letting us use some of their urgent slots, particularly if someone's presenting with psychotic symptoms, they need to be seen pretty quickly. So generally we've met that quite well, and I think that's supported our reduction in DUP, so duration untreated psychosis. So what we've seen is that when we first started, up until January 22, our DUP rate, our median DUP rate was 12 weeks. That's now down to 6.8, I think. So we're continuing to reduce our DUP, and before our service was there, we were picking up our initial people at DUPs of over 100 weeks. So we've definitely seen a massive reduction in that, which in turn has huge impact on the person's outcomes moving forward. So that's been a massive positive for us. Our engagement rate as well, so keeping people engaged within the service is at 97%. And I think some of the challenges relate to the rural nature of that as well. I think we've had to put the miles in. Jamie and Gordon, particularly our peer support worker and key worker, travel the length and breadth of D&G really to make sure people remain engaged. They're on the phones constantly. They're taking people to appointments. It's really that active engagement that's been massive to support people's treatment moving forward. If we move on to the next slide as well. So another massive impact that we've seen is our hospital admission and readmission rates. And funnily enough, our readmission rates are exactly the same as Tayside's, around that 23%. And that's much lower than both our local and national averages as well. Our admission rate, so the maths doesn't add up there, but the admission should say 55% is of people that's generally at their first point of contact with services. Although we have seen, if you were to take that data from the start of January last year, that's down to lower to 35–40%. So we're seeing inroads into people not needing admissions even at first point of contact. And that's generally down to people being identified sooner through CMHTs and crisis and managing to keep people out of hospital with home-based treatment and support from EIP as well. And I think that has been a massive impact on us securing continuing funding within the health board, that we're seeing a massive reduction in the readmission rates from what we were seeing previously. So we tracked the 12 people a year before EIP was introduced to the region, and their readmission rates is above 50%. So we've seen a massive reduction in the number of readmissions since EIP has been introduced. And that's been massive in us securing more funding moving forward. And then I'll pass on to Katie to chat about another couple of impact points.
If we move on to the next slide, please. I mean, this is what we're all really passionate about, which is, as well as providing treatment, thinking more holistically about the outcomes of our service users. And we've been able to work really assertively and intensely with people to get them back into some sort of employment, education or volunteering. It's been hugely beneficial to have the flexibility of our multidisciplinary teams. So we have occupational therapy input as well as obviously psychology. We've managed to offer psychological therapies to 47% of the people that we've been supporting, which, if you think about that stark contrast to the statistics that Susie was talking about access to psychological therapies, there's plenty more to do. And now that we've got permanent funding, we'd really like to kind of advance things further and provide training to the CMHTs and think about support to families and friends. We have offered behavioural family therapy, and that's been hugely successful with the people that we've supported. So I think it touches on what we spoke about earlier, just about the challenges of working in the service at the moment. We all absolutely love what we're doing. That comes across from what Tayside were saying too. I think there's a lot to be said for staff being able to offer a service to people in a way which we know works and has great outcomes. It improves the morale of the staff being able to do so, and certainly I think that's hugely important in the current climate. And I think we've got one more slide, David. Yeah.
Yep, move on. So this is just some of the feedback that we've received from people throughout the service, and this is a small snippet of it because we have had quite significant positive feedback, both from families, service users, but also from people from other services, reaching out. Social work, our inpatient services, our community mental health teams have all been really positive about the impact we've had and our availability and the difference we've made to people. I think it's good in this current climate when things are really tight that people are still seeing we can develop something and we can make a real difference and we can implement positive services moving forward. So it's gave a lot of people a bit of a spring in their step within the services. Just a disclaimer, I didn't write any of these feedbacks and we didn't pay anybody either. So, but they are named. There's some names dropped there as well, Jamie and Freya and Kate and Esther, who's presenting after us as well, who would have been the patch psychiatrist for that person. So let people read through them. And then that brings us to the end of our presentation. Hopefully we've made some time back.
You've been great. Thank you so much, Katie and David. And I think, there you go. Can you see the plethora of applause? the small yellow hands that you are being gifted. Thank you for sharing all of that. And again, it's been amazing to see the difference that setting up this service has had in just, you know, in a not very long time scale. It's made such a big difference, and you can see from those quotes just how much it means to people to be able to gain support for themselves or their loved ones in a time of complete turmoil, when people are really exposed to things that they are very uncertain about and that maybe have no experience of at all, or if they do, they bring their own fears and worries to that experience as well. So I think the fact that, you know, as you've said, I think the fact that people are name dropped in these quotes is really clear that that human element, the staff, the workforce, the people that are running and supporting people within these services are really critical to the way that the outcomes can happen positively for people. So thank you, and thank you all for your feedback, and it's great to see some of the questions popping into the Q&A section. We do have another time for questions, reflections and observations shortly, but prior to that I would like to bring in Esther Mackenzie, who is also from Dumfries and Galloway, but is here to talk with us today about their work on personality disorder. Now, if I'm correct, Esther, I believe that there aren't slides to go through on this presentation.
No, I'm winging it.
Great, that is perfect, because that means that don't worry anybody, you don't need to put in the chat that the slides are not moving forward for you. It is that there aren't slides. So we're going to hear from you, Esther. Thank you so much for taking the time to be here today. I know there's 100 other places that you could have been just at this moment. So it's great that you have managed to be with us, and over to you. And I'll pop back on the screen should you come, you know, should we need to just be at the point where we're rounding up, so that we get a chance for people to ask questions. Thanks, Esther.
Lovely, thank you very much. I apologise in advance for winging it a bit here, as it's interesting listening to the last couple of presentations that people talking about the lack of psychiatry input into everything, and being one of an increasingly small number of consultant psychiatrists, I'm a bit overwhelmed at the moment. We're having to wear quite a lot of hats. I'm going to talk to you about the BPD pathway, the EUPD pathway in Dumfries and Galloway. David very conveniently has given you quite a lot of the sort of detail about Dumfries and Galloway, so I don't have to go over that. We're a very rural area. It's a long way from here to Stranraer, which is our second biggest town, mostly just filled with trees and sheep on the way. So when we started thinking a very, very long time ago about a service for personality disorder, that was one of the major considerations that we had. This pathway has really been about 10 years, or more than 10 years, I think, in the making. I started in Dumfries and Galloway in 2009 as a registrar, and have been part of this work ever since, really. The pathway has now been up and running for a few years. We obviously had, along with everybody else, had a bit of a bump during COVID where everything fell apart. But what I'll do is I'll tell you really a bit about what the pathway looks like, and I'm more than happy for the HIS people to share the pathway with you. I mean, it's not a secret. I just didn't get around to getting it to everybody before this meeting, but I will share the pathway with you. But I'll tell you a bit about it, and I'll tell you a bit about the particularly with the challenges with supporting staff with this. So our personality disorder service has always been very much based on a model that we have, the few of us in the service, and the most there's ever been working for this service is, 4 people, all of whom have had 1 or 2 sessions to do it in. So it's never been a huge service. We have never provided a standalone service for people with personality disorder for a number of reasons, partly because we're such a huge geographical area, and actually we just don't have the resource to have specialist teams in each area. But also because I think we've always felt very strongly that helping and managing people with emotionally unstable or borderline personality disorder is very much core CMHT business. And I think that's a view that's become more accepted. I think when I first started in psychiatry about 1 million years ago now, it was not seen that way, and it was very much, we don't treat people with personality disorder. But things have changed and things have moved on, and although it remains a somewhat controversial diagnosis, I think it is very much accepted that it is a diagnosis and that there is treatment available, and that has to be the key, and that people with EUPD struggle, you know, as much as quite a lot of our other patients really, and have similar difficulties and similar distress and going forward. So we very much felt that dealing with and managing EUPD was very much core CMHT business. So our model was always that we provided support into the CMHTs to help with that management. We went through a number of phases of thinking what would be a useful way of treating people, and actually in the end what we settled on was structured clinical management. So for those of you who don't know, structured clinical management is a evidence-based therapy developed by Anthony Bateman and his colleagues down in London. So it's based in the NHS, which is obviously useful. It has a lot of similarities with most of the other evidence-based therapies for EUPD, including dialectical behavioural therapy and mentalisation therapy. And in fact, it was developed originally by Bateman and his colleagues as a control measure against their mentalisation group, although it actually performed just as well. And it was really set up with a very pragmatic view that it's a program that it's a talking therapy program, and it's based around education and then around skills that they recognize that their nursing teams already had. So it's a way of putting those skills and into a structure. So it consists of 2 phases. So the sort of first phase is education, is around it's individual work, and it's around education and crisis management and helping people understand the diagnosis and developing plans that help them manage when things go wrong. And for actually what we recognize is that for most people who come into our services, often that is enough, that actually these are people who already have lots of resource, and helping them learn how to manage when things go badly is often kind of what they need. The second phase, for people for whom that's not quite enough, is a group phase, and that lasts for up to 1.5 years. And there are 4 modules in that group. They are problem solving, living with emotion, impulsivity, and enhancing relationships. And I had to write those down because I can only ever remember 3. It's never the same 3. And that group is the modules rotate. So you do problem solving, then one of the other modules, then you go back to problem solving, and then another module, problem solving, and then the last of the modules, and you do the whole thing twice. And it's there are no absolute hard and fast rules about how often it is, or whether it's closed group or open group. We run open groups, and problem solving tends to be the block where people drop into it because it's the one that's repeated. And most of our groups run fortnightly. We have within each CMHT, of which we have 5, as David's already said, we have nursing staff who run the groups. So there are challenges, as you can imagine, because none of our nursing staff had run groups before, and patients automatically don't want to go into a group. I mean, everybody is very clear at the beginning they don't want to do a group. But usually, actually, what we found for people for whom the group is felt to be helpful, by the time they've done the individual work, they are willing to give the group a go. And once they're in, a lot of them do stay in. We have a very small dropout rate. We are running groups across 4 out of our 5 CMHTs at the moment. One of the CMHTs hasn't picked up again yet recently, but they are about to start. And the nursing team are given protected time to do that. So it's the pathway essentially is people are referred into the CMHT by all the usual routes, so usually through the GP or through the primary care mental health team with a suspected EUPD diagnosis. That diagnosis, they are then seen in our joint assessment clinics, as everybody who's referred into the CMHT is, which is a sort of medic and nurse-led assessment. And if the EUPD diagnosis is made, they are then immediately offered structured clinical management. There is a bit of a wait depending on which CMHT you're in, and depending on the capacity of the nursing staff in that team at the time, as sometimes how quickly people get picked up. But it's not a huge wait, and it's usually, you know, it's a few weeks at the most. And then treatment goes on from there. There are obviously other people, there are a lot of people already in services who have that diagnosis. And interestingly, I had a conversation in the coffee queue this morning with one of the nursing staff who said she's very pleased because in their CMHT, they've now got all the people who were sitting with the diagnosis already in their CMHT. They are now all have either been reviewed and tidied up and discharged from service, or have been offered the group. So there is, as with anything, there is a bit of a backlog, and there are some people who have get into the sort of SCM pathway by different route. So if people don't want to do the group, we're very clear that as long as there are no immediate risks and the work is done about making sure the risks that they do have are managed as much as possible, then they are discharged from the service. We don't offer people lots of other things because they don't want to do the group. So we're quite clear about that. Like all things, it doesn't always run particularly smoothly, but we're getting better at saying, you know, this is the pathway through care, and actually we've got quite a lot of people coming out the other end of the groups who are then discharged from the service, and who have gone on to manage very well. And we've also had lots of positive feedback. I haven't written any of it down. I should have done, but I was glad to see I was name checked in the last feedback. In terms of staff challenges, I mean, the nursing staff have felt very anxious about this, which I think is understandable. This is a notoriously difficult, challenging group to work with. And our staff had no experience of running groups, so I've had a bit of training in actually just how to manage a group. But a number of our staff have really picked this up and run with it. And those that have talked a lot about how rewarding it is, and actually have become quite enthusiastic at encouraging other staff to get involved as well. We provide them with supervision. They have a peer support group as well, and they invite one another to come and, you know, anybody who's starting and thinking about doing groups, they're very keen to say, come along and you can come and be part of our group and see what it's like. So they've been very supportive of one another. And we provide supervision for individually challenging cases, because obviously there are sometimes people who are particularly difficult to manage. So overall, I'm just going to
ask you to round up. Is that all right, Esther?
I was about to do so. Yeah, you do You do have to stop me talking, because once I start, I can talk all afternoon about this. I think the really key thing for us has been that actually this has become normal practice, you know, that we have gone from people thinking this is really, oh my God, this is something completely new, we can't do this, to actually this is just normal practice now. And that we no longer think of people with a diagnosis of EUPD as this is a disaster. We don't know what to do with these people. We've got to fill them full of medicines. We'll have to do, you know, they'll have to be seen loads. We actually are getting people into service, providing them with evidence-based treatment and getting them out of the service again at the other end. I am probably going to run away before you've all got questions. I do apologise, but I have some other things to do. But I will certainly send through some information to the team, and happy for it to be shared with people. So I shall stop talking now.
Thank you so much, Esther. That was a great run through, and it's great to also hear that we can share the pathway from D&G. Yeah, that's like a free gift at the end of a conference, isn't it? Here's one that we made earlier in a Blue Peter-esque way. So thank you very much, Esther, and
very welcome.
And for taking the time out of your day to be here, and good luck with the rest of it. Brilliant. So we have a little bit of a truncated end to this webinar this afternoon. We have some questions and comments in the chat. We also, however, would like to know what you've thought so far. And the reason that we do that now is because every time we put on a webinar like this and we invite speakers from across different regions and services and from different organisations, we need to be able to let people know that people really get something out of these sessions that they can take away with themselves. So we have designed a poll. It's 4 questions. 3 of them are just tick, tick, and 1 of them is, can you write 1 word? So I can't see the poll yet. I'll just, here we are. So this should not take very long. There are 4 questions. I will read them through, but you can answer them as quick as you like. You can go forwards and backwards on them, and everything is anonymous. So please rate your level of satisfaction with today's event. So names not recorded, but we will share the results. You can also see them in the chat if you can't see them on there. The second question is, would you recommend this event or these events to any colleagues, to any peers, to anyone? And you can agree, strongly agree, disagree, or strongly disagree. Can you put in 1 or 2 words, so it will form a word cloud, which is interesting to watch forming, about what learning you will take away from today's event. So that might be about policy, it might be about practice, it might be about challenge, it might be about opportunity, it might be about impact, it might be about substance use and psychosis, it might be about the use of workforce, it might be about the opportunities for stigma work, it might be about anything that you have heard this afternoon and this morning. And the final comment, final question is about, did today's event increase your understanding of how approaches can help your local teams deliver this? So, brilliant. If we can just go on with that, and we'll submit, and there we are. So if we just look at the word cloud, we can see that it changes all the time, but services, pathways, impact, EIP, reform, complexity, hope, which is always a good one, prospects, which goes along with hope. So these are really interesting ways of understanding what's happening. So in the last few minutes, we are going to do 2 things. We're going to invite the speakers to become a very short life panel while we round up some of the questions from today's event. And if you don't feel that we've come to your question, if we run out of time, which I think we're probably going to, don't worry, we will answer each question in writing. But also I've grouped the questions across 3 themes. I think some of them are about the experience of people, so people with lived experience and how we support them. I think some of them are about services and staff, the use of staff and how services are operating. And I think there's a 3rd theme that's about policy and how we utilise policy and ambition at national level to create change at local, regional and national level. However, before that, I would just like, while you're thinking of your final questions, can I ask Jane and followed by Susie to give us just 1 minute each, very short, about your own, what would your word cloud be? But just, I will come in again after a minute. So Jane, then Susie, if that's all right. She can't? Okay. Susie, anything from you? 1 minute.
So yes, always, I have a few things. Number 1, lived experience has been part and parcel of EIP work from the get-go and will continue to be. That is the culture of EIP. We involve people at every stage of care planning, feedback, personalised care, involving families and so on. That's the first thing I would say. The second thing I would say, EIP saves money. So it's an invest to save development. Investing with seed money, some of these services will save all the board's money. Third thing is, how do we have low levels of detention? Partly because the service is responsive. The engaged relationship with key workers means people know they'll get a response when they ask for help, and we pick people up quickly and we respond assertively, which means that we are in a position to reduce the likelihood of relapse, or at least they may still have some relapsing symptoms, but they won't necessarily need unscheduled care and detained to hospital. So that's what I would say to try and answer some of the EIP questions. Necessity is the mother of innovation. We have to do things differently in mental health. People with complex mental health problems have been forgotten about or maybe not prioritised. And the example that Esther has just described of the PDIP pathway and the examples that we've seen from Tayside and D&G are so impressive. I think they are real practical examples of how we can improve the quality of mental health service provision for people with complex mental health needs. And we're showcasing it can be done in dispersed areas, even with the recruitment pressures. So I really think there's an opportunity to scale up some of this. And thank you.
Thank you very much, Susie. That was a good roundup. Jane, you could just have, you've gifted Susie that time, but I think Jane may also have frozen. So I am going to try for 3 questions in 10 minutes. 1 around policy into practice, 1 around staff and services, and 1 around people with lived experience. So hopefully we still have Gavin Gray on the webinar. There he is. Thank you very much. So there are a number of different questions around policy. The 2 that I would link are, how do we move from a focus on waiting times to a focus on what is needed for people themselves? And alongside that, how could we use policy to increase the likelihood of VIP services and decrease the overwhelm that services feel from the things that arrive at their door, such as ADHD? So there's a bit around the use of policy and government direction, Gavin. I'll come to you first, but that doesn't mean that other people don't have an opinion.
Yeah, thanks, Rachel. So I think with the first one on waiting times, as a lot of times these targets are really helpful in raising the profile and driving investment, and I think we've got a lot from that, particularly around the focus on CAMHS and psychological therapies. But I think through the strategy, we're quite open about the fact that we need to be, we need a broader set of outcomes that look, and we've tried to set those out and look at how we are linking that to delivery. So yeah, absolutely agree with that. I think that just, as always with these things, it doesn't happen quickly, because we've got to try and work with partners to identify what those things look like, what the measures we've got. But we are continuing to work with PHS and others around this about how we get a broader set of quality outcome indicators. And I think I think there's actually some data being published today on that, which is showing again another couple of indicators, and we will continue to have a body of work looking at that, and hopefully there'll be more of that over time. And then the challenge for us is, how do we drive that into our conversation with boards and with IGBs around what's working, what's not, and how that fits into our discussions around support and intervention and engagement with boards. So that's definitely a big part of the work we're doing at the moment. So I think we absolutely recognise that. I think the other nice easy one about how we take these bits of work and embed that in the system. I think there's definitely this has to be a two-way but multifaceted thing. I think we have tried to through work like this with yourselves and others who have funded that, tried to get those bits of work going. But the challenge, so I suppose there's 2 challenges. On the one side, what we're trying to do, and again, this not just in mental health, but across health and social care, is baseline more of the funding for boards and others, so that there's less ring fencing of funds to allow boards to make those decisions about where they're investing and what they're doing. So within that, how do we try and help make those cases for things like this? And again, the conference I was at yesterday, the learning event, there was a lot of focus on the particularly around EIP and the benefits that can have. So I think it's just about how we think about the approaches. Is it the right way for us to fund these things separately and try and embed them, or do we try and work, do we have the right mechanisms in place that are able to highlight that good practice that's going on, and try and make sure that everybody across the country is able to access that, to understand what the cost benefit analysis of that might look like, where the savings might come, and how they how they do that in their own service design. So I think we've started talking about how we might look at things like operating models that might help set out that as a not as a here is the way that we think services should be delivered, But as always, you know, the role for us in government is often, to, you know, what can we take from what's happening around the country and how can we play that back in the way that we've done around the development of standards or some of the specifications. So could we work with services to develop what an operating model might look like that areas could then use as a blueprint to try and answer some of those questions around where, you know, actually, can you make those cost savings? I think, you know, I've been having some conversations with colleagues this morning about, you know, how we improve support for people with really complex needs where we know that, you know, maybe the care and the treatment isn't in the right place, but it probably in areas of the system that are quite costly as well. So how could we maximise the use of the resource that's already in the system? Now, that's easy to say, but, you know, it's quite difficult for us to find the ways to do things. But again, that's a big part of the challenge coming out of this about how do we have the right governance mechanisms, you know, as the operating models of those things are those the things that will help. And we want to have a real dialogue with folk and services about, you know, actually what is the best way. There's always 101 different views on how you do that, but we really want to get that sense of, you know, where can we really add value and give that support to facilitate that, you know, the local decision making and the delivery of services being led by people with lived experience, you know, people with in the front line who are the ones that've got the expertise. You know, that level of detail shouldn't be coming for us, but we need to create the environment that facilitates that change and reform and is able to ask the right questions around what's happening or what's not in those areas.
Thank you very much, Gavin. That was, you know, a full answer, and I think that shows that relationship building between the local and the national, and where we can put the emphasis and the understanding. And I think it's a moving vehicle, isn't it? Really, this as we understand better and do better by understanding more. So thank you. I'm not going to come to anybody else on the panel for an answer to that, and I am going to put together two questions, one that's about services and one that's about people with lived experience or people, which I think follows on from what you have just been talking about, Gavin. There were some really interesting comments and questions in the chat about, can you tell us more about the role of OTs? Where are AHPs in this multidisciplinary team? Can we use our clinical psychology associates better? Can we use more IPS employment workers better? Can we use trained interpreters better? So all of that sits here. But the two that I'm going to bring together that are around the experience of people, what happens to rejected referrals? We saw in D&G that there was 97 referrals, but 47 accepted. So what happens to that other 40 odd people, 50 odd people? And a question that goes alongside that, which is, there are low levels of compulsory treatment for EIP patients. Why is that? Now, I think we know some of that, Susie, because of what you outlined initially. But those two things, what happens to people who don't get in to these pathways? And once they're in these pathways, what are some of the benefits? We have 3 minutes. Who wants to start that off? Katie, do you want to start? Susie, you've come in first, fastest finger first. So a minute from Susie and a minute from Katie, and then we try to round up by 1 o'clock. Should be fun. Let's go.
So I think in EIP, some people go on to CMHT because their needs are best met by CMHT. So we are specifically trying to target the resource at the most marginalised group who haven't traditionally had access to those interventions. Other people need a trauma service, or they need to join up with treatment for depression or whatever. So a lot of our referrals are people who go to CMHT or primary care teams or trauma. Some people don't need anything. It depends, I guess, is what I would say. In terms of the detention rates, the main thing is the engaged relationship. So we are lower users of unscheduled care if people are being seen in the EIP, because there's such an important engaged relationship with the families as well as the young people, and they know they're going to get a response, and they help seek when distressed, not all, but often. And so things don't get so to escalate to the point that they need unscheduled care all the time. Obviously in Glasgow we've got 250 patients. We definitely have people that get detained to hospital, but by and large it makes a difference in terms of detention rates. And also the staff have the time to assertively outreach people they're worried about, and that makes a big difference because it means you can prevent problems, and it's all about prevention and self-management. That's what the strategy says, and this is it operationalised. That's me. Katie?
Thank you. And Katie?
What I would add to that is that, and I think this is one of the benefits of EIP, where you have that specialist resource and experience, that we very rarely reject a referral on the basis of a letter. You know, if there's some suggestion that somebody is experiencing psychosis, then we would be involved in providing extended assessment and really thinking about what is the best support that they could have, whether that's being taken on by our team or supporting the existing services to help manage their care. So although there's a percentage of people that you know, following referral haven't ended up with our team, and I think Tayside said this too, there's a small number of people where there is diagnostic uncertainty, and they would benefit from intensive assessment and support to really tease out what are the main issues here, what treatments would be the best course of action. And I think that's one of the other kind of benefits to have that kind of specialist resource. You know, it kind of disguises the amount of work that's happening when you just look at the people that are followed up. There's a lot of work done around people who there's a query around psychosis, and then there have been people who we've maybe initially thought aren't for our service, but ultimately they have then transitioned towards a first episode psychosis, and because we've had that prior relationship with the service user, their family and the existing referrers, the access to us, I think, is quicker because of that.
Thank you so much, and I'm sorry to truncate everything at the end. I think we could have talked for another hour about all of these issues and more, and I would like to just give my thanks to everyone for being part of today's webinar, and for all the questions and for all the comments and for all the connections, but particularly to our panel, Jane and Susie and Katie and Gavin and Diana and David and Donna. Thank you so much for being here with us this afternoon and seeing those conversations take hold. So thank you. You'll see in the chat that there is time or a place where you can get more information, and if you would like anything followed up, we will of course give that time as well, and we will give a written answer to all the questions that we didn't have time to get to. So thank you all very much. I hope you've all got lovely lunches waiting for you and have lovely afternoons wherever you are. Thanks very much, everybody. Bye bye now. Thank you.